Okay, so welcome to this Nutrition Nuggets educational webinar series, webinar number 2. We enjoyed the last webinar and there will be a third webinar scheduled on the 30th of June. So we welcome now Julie and Chloe from a Great Ormond Street Hospital in London, United Kingdom. Over to you. Thank you.
Hi, thank you for having us. My name, as Mary mentioned, is Julie. I am the clinical lead for dietetics in hematology and oncology, and Chloe is the lead for bone marrow transplant and immunology. And we'll hopefully, um, go through what we do today. Let me just share our slides and we'll get started. All right, again. Can you see the slides?
Yes,
Perfect.
Julie.
Yes.
All right, so we're going to give a bit of an overview of nutritional management during treatment in cancer, and also considering the evolving practice around the gut microbiome. Right, so here's a bit of an overview of what we'll cover. Okay, so I think before we get started, sorry?
No, there was just an echo, Julie.
Okay. All right. Before we get started, I think we just want to set the scene a bit of kind of what the landscape looks like for advances in childhood cancer and the outcomes. So as we know, in childhood cancer, the survival rate has doubled since the 1970s, and up to 84% of there's an 84% survival of childhood cancer for 5 years or more. However, survival varies considerably depending on the diagnosis, and there obviously will be differences amongst different countries in Europe. I think what we also need to consider are long-term complications which are associated with childhood cancer survivors, which are severe chronic health conditions such as cardiovascular disease, type 2 diabetes, metabolic syndrome, and certain predispositions to secondary malignancies, which is further prompted by nutrition-related problems that manifest during treatments. What we are identifying is a lot of these long-term complications originate from nutrition-related issues during that initial cancer treatment. So when we're thinking about nutrition challenges during cancer therapy, there are lots of different factors to consider. So we have the cancer itself and the underlying disease and the inflammatory response that can result from that. So they're likely to have increased metabolic demands. And then what you may find as well is then how they're impacted by the treatment process. So they may experience toxicity of treatment and the side effects associated with that, and that will vary depending on the types of therapy and how multimodal it is. So if it's just chemotherapy versus chemotherapy, radiotherapy, autologous stem cell transplant, surgery, etc. And then we're thinking about the environment and the impact of long-term hospitalization and limited access to typical foods. So not only are we dealing with the metabolic effects, the physical effects, and the treatment effects, but we're also thinking about how being out of their typical environment, dealing with the stress of a diagnosis, and being in a long-term hospital setting with limited access to their typical food or even preferred foods or preparation styles, how that can impact nutrition. And then, of course, the psychology associated with treatment, diagnosis, and the changes that the children have and the families undergo. So there's quite an impact on feeding dynamics. And there can be a lot of stress between parent and child, and the focus can often move to just trying to get them to gain weight when they're not feeling well. And there can be a lot of negative associations that develop with feeding and psychology with children during cancer treatment. So it has a real impact on their growth and development and their needs. All right. So what we find is children that are at high risk of developing nutritional deficiencies and that they have body weight and body composition changes. So I think the discussion now is shifting. We're not just worrying about undernutrition, but we're also thinking about overnutrition. And we can't just be thinking about getting weight gain, but we have to be thinking about lean muscle mass and rather than just increasing fat mass. And the impact of body composition on nutritional balance. And then just thinking about how these nutritional changes impact growth and development during treatment. So as I mentioned, we're thinking about over and undernutrition and the impact on clinical outcomes for diagnosis and long-term survivorship. So if we first think about undernutrition, it has been found that without nutrition intervention, up to 50% of children treated with childhood cancer are likely to become malnourished or undernourished. Obviously, there will be variation depending on the type of cancer, the stage of cancer, and the type of treatment. For example, leukemias, there's more of a 5 to 10% risk of malnourishment at diagnosis and 0 to 5 during treatment. Whereas you'll see with the neuroblastoma, it's almost half. So you've got 50% at diagnosis and up to 20 to 50% during treatment. Whereas with solid tumours, there's a much wider range. And again, that's probably due to the variation in the tumour presentation, the staging, treatment risk, and multimodality of treatment. So although we know undernutrition is a big risk, it's important to consider how it's affected by the different state treatments and the different diagnoses. So when looking at undernutrition, the important thing, which is quite challenging for us, is that there isn't a set consensus on the specific definition and how to identify children at risk. So we have screening tools, but we don't have a standardized consensus in where we can routinely identify when our children are at risk. And that's highlighted partially by the above information, that there is that variation, which is hard to standardize and account for. Some children, it's also important to note when screening and we're looking at weights and heights and, using these anthropometric measures, that can be skewed by larger abdominal masses, edemas. They may present with a normal weight, but when you're physically assessing them and you're looking at, using other measures, you'll be able to establish that they're underweight. For example, if you were to use the mid-upper arm circumference or just your, critical analysis of how they are. So when looking at undernutrition, it's important to remember how significant the consequences can be and why we do prioritize maintaining a good nutritional status so much. So if a child is undernourished during treatment, it can increase their length of hospital stay, it can increase their risk of infection and complications, it can increase their risk of drug toxicity, and it can increase their risk of mortality independent of disease severity. In addition to that, it can reduce their tolerance to chemotherapies or reduce their tolerance to therapies and responding to therapies as optimally as we'd like. It can reduce their quality of life, and it can have, as you would expect, a negative impact on their growth and development. Now, as we mentioned, we're not just thinking about the negative impacts of undernutrition, we also need to consider the risks implicated with children being overweight or obese or overnutrition during treatment. So it's important to remember that over the last 30 years, there has been an increase in obesity and overweight children overall, but then also significantly in children and people undergoing treatment for cancer across all stages of treatment. At diagnosis, the incidence of being overweight and or obese is 15%. And in our ALL cohort, the highest incidence out of all types of childhood cancer is 20% at the beginning of being a risk of being overweight or obese and 40% at the end, which is quite a significant increase. What they're also finding is that when they're coming off these long-term steroids and these intensive treatments where they're gaining weight, they're actually maintaining the weight beyond treatment. It's not like the steroids finish and then they return to their pre-treatment weight. So what they're finding is these long-term effects on metabolism and chronic health condition are staying with them in 30 to 70% of ALL survivors. So obesity is also the most commonly reported late nutritional effect in these childhood cancer survivors. So it's also important to remember how prevalent it is. It's not just our ALL patients, and we need to be thinking not for keeping them just healthy towards the end of treatment, but the impact post treatment completion. And this is something that our survivors are dealing with. It's important to remember just in the little blue box there that obesity is also associated in some of the spinal cord or brain tumors, lymphomas. Um, but it's, it really depends on the treatment itself. Okay. And then when we're thinking about how this happens, how do our children become overnourished during these treatments? It's important to remember that etiology is multifactorial. So a lot of our children, when unwell, will have sedentary behaviors, partly because they're lethargic and not feeling well, partly because they've got lots of hospital visits, partly because they might not be able to do all the activities that they would have done previously. So overall, they're moving less. You're also finding that depending if it's a certain type of brain tumor, they may have disrupted hypothalamic function. They develop poor dietary habits. So in our ALLs, we know that long-term steroids can increase appetite, and we know we can kind of see the driver for the poor dietary habits. But it's also important to remember some of those children who may have poorer intake during treatment, we relax a lot of the rules, and the foods that they're choosing may also be quite poor quality, high fat, high sugar, and those habits can stay with them post treatment completion. There may be other complications like growth hormone insufficiency, as I've mentioned, long-term steroids, and then of course the impact on the gut microbiome and the dysbiosis that all these treatments, antifungals, antibiotics, IV meds of whatever description, can have, well, not just IV, but can have on the gut microbiome. So those are all the multifactorial reasons why we might find our children are resulting in these long-term effects of being overweight and obese. So when we're thinking about the impact of overnutrition and what it's associated with, so what we find is that high BMI has been linked with high rates of fatal infections in AML patients, increased mortality in AML, increased incidence of adverse events in ALL, treatment-related toxicities in ALL, including hepatotoxicity and pancreatitis. We're also looking at increased risk of nephrotoxicity, nephrotoxicity and post-operative complications in osteosarcoma. They're also finding that there's a reduced chance of event-free survival in ALL and reduced survival in osteosarcoma and Ewing sarcoma. So they're finding that obesity during induction is an independent predictor of persistent minimal residual disease in ALL as well. So you can see that there are quite a few risks associated with overnutrition. I feel like over the years we spend a lot of time trying to keep our undernourished kids, getting them back on track, but we also need to be thinking about overnutrition and the long-term impacts of that. And then just to mention, of course, we're looking at over and undernutrition, but we're also looking at quality of nutrition. And, we have to think about what that impact is on the body. And an example is with our ALL children, the impact of bone health. So what you may find is with their long-term steroids, with the chemotherapy, reduced physical inactivity, they might have vitamin D depletion, increased body mass composition, so increased fat-free mass. They may have mineral abnormalities and nutritional problems. And this can come from the large cumulative doses of steroids and methotrexate. They also have an increased risk, sixfold higher in an increased fracture risk, in the sixfold higher than the general population. So what we try to do is routinely check vitamin D and advise supplementation within the current national guidelines. But it's just important to remember we're not just thinking about over and undernutrition, but we're also thinking about the impact of the micronutrients and how that impacts bone health and many other functions in the body. So as I've mentioned with diet quality, we need to be thinking about nutrient intake and what we're taking in. And there isn't much evidence or much information out there for our cohorts, for our young people undergoing cancer treatment. But what there has been found is that there are general trends of excessive energy intake, saturated fat intake, refined carbohydrate, and increased or raised sodium intakes. In terms of energy intake, it is important to note that that might not apply for children receiving high intensity treatments or regimens on requiring nutrition support. But overall, with the information that is available, we're finding that there is a poor quality diet for our cohort. and there's poor adherence to dietary guidelines. So in ALL, the diet-based, what they have found is diet-based antioxidant intake is associated with decreased infection rates and mucositis after induction. So what they are finding is getting better nutrients, or in this context, antioxidant intake, is you might find better outcomes. So I think although that's not necessarily a guideline in and of itself, it's indicator for us to be thinking a little bit more about the content, not just calories in, calories out. So when thinking about micronutrients, we can be thinking about, again, there's limited evidence, but here's a few pieces to support why it's important to be thinking about micronutrients. So there's emerging evidence around micronutrient abnormalities showing a negative impact on clinical outcomes and possibly impacts on treatment complications. So for example, lower selenium can result in higher complications, and zinc deficiency is associated with adverse outcomes. So again, it's to get us thinking a bit about the impact of treatment, how it can result in micronutrient abnormalities, how often the dietary intake can be poor, and actually thinking about how to best modify this or reframe how we support our children. So the takeaway really is the equilibrium of nutritional status. So we're not looking at just underweight. So we're not just focusing about overweight, we're looking at finding that balance, because we know if our children are underweight, we're not able to meet their growth demands. They might have, poor lean muscle mass, they might have poor nutritional intake, and they might have these increased metabolic demands that we need to meet. On the other hand, if they become overweight, they may have this increased fat-free mass, they have poor dietary intake, they may be physically inactive, and they may have an impacted growth hormone, and of course they may be on long-term steroids. So it's about finding that balance, because either of those can result in gut dysbiosis and can have poor diet quality and poor micronutrient provision. So how do we address that? And I suppose that's where we start to think about early intervention. So although we don't have these broad standardized nutrition screening tools, can that be something we continue to work on and tailor and screen our children early based on diagnosis, based on staging and treatment plans? Having always that multidisciplinary input, because we as dietitians know why nutrition is so important, and we can focus on all these things, but we need the support of the wider medical team to understand the direction of care for each individual child, the risks associated, what the expectations are for their treatment journey. And then of course it's always a patient-centered approach. It's not always that one size fits all. There's often, a lot of our children have different needs, and it's not just underweight and overweight, but it's whether they are at risk of more certain micronutrient abnormalities or deficiencies, or certain gut dysbiosis based on their treatment, based on what they are managing to take in, and then tailoring and providing this enhanced and advanced level of nutrition support for them. And then the thing that I think we would love to spend more time on, and hopefully are in the years to come, is also those eating behaviors. So it's not just about what they're taking in, it's the environment and the context in which they're taking it in. Are they able to eat with their families and their siblings? Are they able to take time away from their bed and actually sit at a table? For our little ones that are weaning, are there enough high chairs or play mats available to support messy play? How are we supporting parents to manage stress around eating? So how do we support that positive eating environment and try and reinforce those positive eating behaviors? So those are all the aspects we try to consider when focusing on creating energy balance and nutrition optimization for our children. In terms of the strategies that we can use, of course, so for nutrition support strategies, we support eating and food as best we can, and food fortification. So oral feeding strategies is, our bread and butter, so to speak. And then we work our way up the pyramid based on how they're doing, what their needs are, the acuteness and the severity and intensity of their treatment. So they may require oral nutrition supplements, obviously with taste changes and aversive feeding behaviours and periods of feeling unwell, oral supplements might be hard to get good compliance. We try to be quite proactive with enteral tube use in our high-risk patients. So rather than waiting for them to lose weight and doing a lot of negotiating with oral supplements and eating and creating that stressful feeding dynamic, if we know they're going to get to the point where they need the tube, we try and foster a positive framing around the tube and encourage proactive approach to maintain and optimize nutritional status. And then of course there will be periods where, in conjunction with the MDT and working with the wards and the families, they may need periods of gut rest where they require PM. So those are the strategies that we work through when managing our children. And this is just a bit more to elaborate on that. So when we're thinking about tube feeding, we know that early enteral tube feeding does improve nutritional status during intensive treatment periods. We know it's associated with lower incidence of infection in comparison to PN. And we know it can maintain and restore gut integrity, which us as dietitians were all about. Early intervention can prevent nutritional decline. We're very pro prophylactic placements in high-risk cases so that we're not on the back foot and we can actually support them maintaining their nutritional status. And of course, we need to think about it in context of if and when they're developing mucositis and checking platelets to make sure that they're not a bleeding risk. So making sure we're getting ahead of the game, because if they're in a place where they can't get it placed anymore, they might be on PN, where actually we could have maybe gotten by with enteral feeds. And then also what we find, and you know, I'm sure we've all been in that time where there's a bit of a push and a pull between the families and whether they need an NG or not. But a lot of the time we describe it as, you know, it's just another tool in their toolbox, another thing in their arsenal to support oral intake. So I'm always keen to say it's not to take away from their eating, it's to support them in addition to. And what often it can be is a big relief to families because they're no longer stressing to try get enough nutrition in. They know that these early interventions can support them. And then also it's always useful in terms of meds and fluids. But in terms of early intervention, we always need to be thinking about MDT collaboration, help managing expectations of being quite clear and transparent with the families as to what is to come. Always considering the psychological and psychosocial situation and providing or offering support where possible, depending on what your service can offer, and thinking about the diagnosis and the prognosis and the stage of treatment. You know, there are times where if unfortunately it's multiple relapse, the child's non-curative and it's more for palliation than comfort, and an NG causes great distress, is it the most appropriate? Possibly not. So we always need to think about the context of the treatment, and that's why our MDT collaboration is so key. So yeah, and then of course thinking about our patients and their preference on what is acceptable to them. In some contexts, we might need to be consider jejunal feeding if there's prolonged vomiting or gastric motility issues. And here's just a screenshot of what has been developed in our hospital, that we have an early enteral feeding recommendations to try and help standardize early enteral feeding. And I think for us, you know, we want the medical teams, the nurses, you know, the doctors, ourselves as dietitians all to be saying the same thing. So when we're able to share this kind of standardized guideline, it really helps consistent messaging, which I think families really appreciate, but also in terms of collaborative working, it's really helpful. So yeah, that's basically my overview of where we are with nutritional management these days, the strategies that we implement to support our children, and how we're moving forward. I'm going to hand over to my colleague Chloe to discuss a little bit more detail about feeding strategies. All right, thank you.
Swap that.
Yeah.
Sorry, just changing positioning quickly and getting a charger in. You never know when these things last.
Thanks, Julie.
No
Hi,
worries.
Chloe.
Okay, fantastic, great. As Julie mentioned earlier, my name's Chloe. I'm one of the dietitians here at Great Ormond Street, and I work with patients undergoing bone marrow transplants and immunology. So I'm going to be talking about our recent change of practice we've had. here for our bone marrow transplant patients. And that's mainly based on the increased evidence thinking about things like the gut microbiome, which is an increasingly trendy word for the general population, and becoming maybe a little bit more trendy for our patient group as well. So when I talk about the microbiome, I'm talking about the community of microorganisms, which are mainly based on bacteria, but also things like viruses and fungi. And there are approximately 100 trillion of these microorganisms that are existing in the human GI tract. So here on this diagram here, you can see on the left-hand side, this is what we would consider a healthy GI microenvironment, supported by good bacteria. And actually for the general population, as we know, there's strong evidence that having this balance in the microbiome is linked to good health, reduced disease, as well as strengthened immunity and reduced inflammation. But actually, in reality, for our patient cohort and with the treatments that they have to go through, we're much more likely to see a microbiome on the right-hand side, which is unhealthy and unbalanced, as we see there. And we can see that this dysbiosis is a consequence of things like antimicrobial drugs, chemotherapy, radiation that these patients go through, as well as mucositis, which has caused this imbalance in this environment. And actually, more specifically, the dysbiotic changes that occur in the gut are caused by the disruption of the immunological balance of the intestinal mucosa barrier, which then permits the expansion of enteric pathogens, which again just causes further inflammation. And these dysbiotic changes in the gut microbiota can predict a range of life-threatening consequences, such as further exacerbation in GI mucositis, febrile neutropenia, bloodstream infections, as well as malnutrition, obviously, which is our area, and relapse and mortality. So moving on to the next slide. So as I mentioned, this is becoming a bit more of a trendy word in the research field for this patient group. And there's a growing body of evidence looking into the microbiome in the allogeneic stem cell transplant setting, and what potential role this may play in the outcomes, particularly something such as GVHD. So in this setting, as I mentioned on the previous slide, there'll be many factors which disrupt the microbiome, including obviously the conditioning regimes these patients have, antifungal treatments and prophylaxis, the ever frequent use of antibiotics, as well as the really prolonged period these patients might have of gut rest and therefore requiring TPN. So a little bit of research in relation to this setting. So they found that having a lower bacterial diversity within the first few weeks after a transplant can increase the risk of acute GVHD related outcomes, including mortality and disease relapse. And in relation to nutrition support, enteral nutrition, unsurprisingly, is superior to that of PN when it comes to maintaining this bacterial diversity and the composition of the microbiome. And thinking about things like supplements, so with the use of prebiotics such as resistant starch and a commercially available prebiotic mixture, which was glutamine, fiber, and oligosaccharides, which were given to allogeneic transplant patients from the beginning of their pre-transplant conditioning all the way up to day plus 28, help maintain microbial diversity. And the prebiotic intake actually mitigated for mucosal injury and reduced the incidence of acute GVHD. There was a cumulative incidence as well of skin acute GVHD was also markedly decreased in the prebiotic intake group. And also thinking about symbiotics, which is a combination of both pre and probiotics, before and during the conditioning phase, which stopped at day 0, may actually lead to a reduction in the incidence and severity of acute GVHD. And then thinking about the diet, which is obviously very much our area as well, and what fiber might play in that. So the diet is a major modulator of the structure and function of the gut microbiota, particularly something like fiber. And dietary fiber is an essential component of the diet that's absolutely crucial for human health and ultimately provides nourishment for the GI microbiota that exists in the gut. So gut bacteria, after someone eats fiber, the gut bacteria will ferment the fiber, which then breaks down into short-chain fatty acids, such as butyrate, which has anti-inflammatory properties within the gut. And researchers found that having the level of butyrate was significantly decreased in all in patients that have all GVHD stages, and patients that had a diet richer in fibre during the pre-transplant period actually correlated with earlier neutrophil engraftment and shorter duration of febrile neutropenia as well. So based on all of this and relating it to practice, we've heard about the role of the microbiome and things like prebiotics, probiotics, fibre, etc., and how we're going to relate that to our practice and hopefully improve the outcomes for our patients here. So enteral nutrition is something that almost everyone will have during their transplant admission, if not for many months or years after it. But despite the fact that every patient will have enteral nutrition, there's actually quite little evidence about the most appropriate feed choice to use enterally in this patient group. And it was very much previously focused on using hydrolyzed and amino acid-based feeds for these patients, with no real evidence to support this, but more based on the theory that these patients have poor absorption because they've got inflammation, and with their chemotherapy and obviously with mucositis, they must need something that's more broken down. But actually, with the developments of the influence of the microbiome, we changed our practice here at GOSH. So actually in June 2024, so a year ago, we started using a whole protein fibre feed as our first line feed for patients, as long as they were over 1 year of age and that they didn't have a milk allergy. My initial thought would be we would start these patients on a fibre-based feed during conditioning when their oral intake decreased, but then they would end up having increased diarrhea, and then we'd end up moving them to a hydrolyzed feed. But what actually happened, the reality is that they tolerated the fibre feed incredibly well, and they developed gut symptoms, as you would expect with mucositis, at the same time as those that were on hydrolyzed and amino acid based feeds. So we certainly didn't see any more diarrhea with these fibre based feeds compared to the other ones. And actually, completely unofficially, I've probably seen more formed stools in the last year than I did in the previous 4.5 years when we were using predominantly hydrolyzed and amino acid formulas. And actually, some of these patients on the fibre feeds continue to tolerate it all the way through mucositis into engraftment and in the longer term. So we never needed to change them onto a different hydrolyzed or amino acid formula. So they didn't end up going on to TPN, but there are obviously patients, as you get in, regardless of what feed you've given them, they have severe mucositis. And these were all patients that had myeloablative conditioning, mainly made up of high-dose busulfan or high-dose TBI, which we all know can be pretty brutal for these children. And just having a look at the short-term outcomes of this change in practice, I wanted to look at the amount of PN that we use, and if we use more or less or the same amount with fibre-based feeds compared to the others. And although the groups are quite different in sizes, obviously the amino acid and hydrolyzed feed is a double the size. That's because we still do have to use these types of feeds for patients that have allergies, and obviously here we see a lot of newborn screening skids, so they obviously go on to hydrolyzed formulas instead of fibre-based feeds. You can see that 56% of them did need TPN on the amino acid or hydrolyzed formulas, and 46% needed TPN those that had a fibre feed. So I need to do the deep analysis in terms of statistical significance, but actually you can see that if you give someone a fibre feed, you're not automatically going to be using more PN in those patient groups. And actually thinking more about the longer term, I'm now looking at the outcomes in terms of things like the development of GVHD and if there's a difference between the patient groups as well. So watch this space, that's to come. And finally, a little bit about trophic feeding and preventing these really prolonged periods of gut rest in this patient group. So as I mentioned earlier, enteral nutrition has a beneficial effect on the microbiome compared to PN during transplant. And whilst in some cases, mainly those with severe mucositis, PN is warranted and essential to help maintain a patient's nutritional status during treatment. It's really important to consider when we're actually going to start refeeding these patients and doing it at the earliest opportunity, either orally or enterally as tolerated, or if we're able to continue some trophic feeds during while they're on TPN with mucositis, if they're able to tolerate it. and thinking a little bit about what the future holds for the next 2 years, 5 years, probably more like 10 or 20 years in some of the cases. But thinking about giving a routine prebiotic or fiber supplements to all patients, and obviously particularly those that have a milk allergy that couldn't have an off-the-counter fiber feed normally, and those obviously under the age of 1 year, and what we could be giving them as well to counteract for all of their microbial treatments, antimicrobial treatments and things. And then thinking about, could we be giving these patients like optimizing their microbiome diet to follow in the months pre-transplant? Is there anything we could be doing for that? Instead of just thinking, oh, have as many calories as you want because you're probably going to lose weight during transplant. Thinking about things like postbiotics, so short chain fatty acids such as butyrate or something as supplements for these patients as well. Engineered probiotics that are safe for immunocompromised patients. I'm not sure who's going to create all these things, but I'm hoping someone will do in the future. And fecal microbiota transplant, maybe having a standard product that can be used for these patient group. I'm sure that's probably more 10, 20 years in the making, because there's really some good evolving evidence for that in the prevention as well as treatment of refractory GVHD as well. And these are the references. Does anyone have any questions? Thank you for your time.
Thank you, Chloe. So that's interesting, isn't it? Because the last webinar, there was a question about using probiotics, prebiotics. So are there any immediate hands up for questions? I don't see any hands. So Kiara Kennedy has posted a question on the chat. So the question is whether for your early enteral feeding guidelines, do you get good buy-in from your colleagues?
I think that's a good question. So I would say, as with anything, it takes a bit of time. And, we work with our doctors and our nurses regularly, and we have a really good rapport. And the guidelines were developed in collaboration with our clinical nurse specialists. So I think because we already had, support of our MDT, I think it has been really helpful. And I do think we've had good support from our colleagues. I think the only challenge, which will be with any teaching hospitals, we get a moving rota of doctors in training or, fellows and specialty registrars. So it's just, we try to keep that regular ward training and doctors training so that they're aware that these guidelines exist. But typically, I think that we've got quite a collaborative relationship and it goes well.
Yeah, especially the different meetings that you all attend together with the multidisciplinary group. For example, the integrated care meeting and the MDT meetings. Also, the ward round. Dietitians are very paramount in the ward rounds.
Yeah, and I think that's where we get that's where we get the best collaboration with early placement, because we get a bit of an insight as to what's to come. And that's when we'll be saying, or should we be thinking together about having those conversations so that the doctors and ourselves and the nurses come away from that meeting all knowing that's the plan.
Okay, thank you. So then there's the second part to the question that Kiara Leon has asked. Would the majority of your identified high-risk groups get an NG tube?
Sorry, the ones that we identified as high risk in that guideline, what we kind of said is we need to be having the discussion. So the guideline is to be saying encouraging it, and ideally that's what we would like. But we do also appreciate that each child needs and each family needs individual consideration. So, some children obviously don't have very much success with them, or they're vomiting them out, or maybe some do a bit better on the treatment and not needing a tube when you think they might. So we still take that individual need into consideration. The guidelines more to be thinking about it early and having the conversation early. There might be additional considerations where maybe it is or isn't appropriate. So in theory, yes, but individually, maybe not as much.
Yeah, but very often the tube is passed down not for nutrition, but also for medication.
Yeah,
and that helps, yeah.
And we try line it with GA so it's less distressing, etc. So,
yeah. So the next webinar will include the tube, NG tube from Princess Maxima. But I have a question for the presenters. So in BMT, you do have probiotics. And well, how does it fit into the practice? I.e., do you prescribe it, or do you get parents to buy it, or what do you recommend
So was that pro or pre, or in reference to both of
in
them?
reference to both?
Both. I mean, to be honest, I know I just spoke about all this, but we don't actually routinely give patients pro or probiotics. Definitely not until they're immune reconstituted, which is generally 4 to 6 months post-transplant. And we don't routinely say have prebiotics. However, by giving them a fiber-based feed, fiber in itself is a prebiotic, and obviously you can encourage them to have prebiotic-rich foods within their diet instead of having a supplement. But hopefully over the next 12 months, we'll think about doing some sort of prebiotic trial here, if we're able to, in collaboration with another London hospital, as a bit of a standard practice for these patients. I definitely think that's something we need to start doing, routinely in this patient group. But fiber feeds was the first step.
Yeah. See, the fiber feeds to balance it off just for the most basic of knowledge. Okay. With in the cases of diarrhea, serious diarrhea, um, what would you advise? Would that have impact, or you're not bothered because it's still stimulating some activity in the gut?
Exactly. And I think in the last 5.5 years, even the 4.5 years I was in transplant and we weren't using fiber feeds, diarrhea was a significant problem in this patient group. And most likely it's multifactorial and generally not driven by the feed in itself at all. And it's much more likely to be things like mucositis, GVHD, these chronic stool positive virologies that these patients have for absolutely months and months and months. So I think that if you give someone a fiber feed or you don't give them a fiber-based feed, they ultimately have diarrhea. And I think if we can be doing something like giving them the fiber feed, will hopefully have some impact whatsoever. We can only but as long as it's not making it worse, that's the main thing.
Yeah, as long as, and because actually, although the diarrhea is getting worse, there may be some absorption of the nutrients, isn't it?
Yeah,
Yeah.
exactly. And also these patients are on 1, 2, 3
Yes.
different IV antibiotics for
Yes.
absolute, days, weeks on end, in addition to antifungals, etc., etc. So I think that's much more likely the thing that's giving them the diarrhea, and anything we can do to support their prebiotic intake is a winner for me.
And would you
Okay.
say,
Yeah.
oh no, I
Sorry.
was just going to say, the fiber containing feeds, I think I often get from the wards is, we associate fiber with trying to get bowels moving. So it's quite common to say, well, should we choose a feed that isn't fiber containing? I think what we often like to remind them is it's the type of fiber, very little of it's even insoluble fiber. A lot of it is soluble, which actually helps with stool formation. So I think in terms of, those basic questions around fiber is going to make the child pass their stools more, it's actually the types of fiber in these feeds, if anything, will help with formation and reconstitution, as Chloe's mentioned, of the gut microbiome, which might improve output. Is that correct?
Yeah, exactly. And I think, as I mentioned, that this is totally unofficially, but I have seen more form stools since using fiber compared to previously. And this is why I always try and start children on feeds during their conditioning, when they're much less likely to have diarrhea, because you're then showing the family, you're showing the nurses and the doctors, look, they've been on this feed for 2 weeks already. Yes, they've now got diarrhea, but that is actually much likely to be due to another problem, because this child has had this feed for the last 2 weeks. So yeah.
That's interesting. So I just want to reach out to the attendees and audience. Do feel free to chip in or raise your hands to speak. You could on your cameras and unmute your mics. There's one question here in the chat from someone in Sheffield, Nair. Yes. So, how long do you recommend gut rest and TPN in case of GVHD?
That completely varies. And it will completely depend on what their symptoms are like. Like, for example, we've got a patient on the ward at the moment that has profuse diarrhea when you give them Diarrhea. They're having 15, 20 stools a day. So, and that's on Diarrhea, that's not even giving them feed. So in that case, you have to give them TPN for as long as you know, they're not able to tolerate, you know, something that's water with a bit of sugar and electrolytes in. But I think as soon as they're on the treatment of the steroids or whatever they've decided to treat it with, I think we should be trying to even just give you know, a little bit of trophic feeds or even just diarrhea to start off with to see about their management. But there's actually no set guide on how long we should be giving gut rest for. And actually, whereas previously I feel like there's always this thought about, oh, if someone has inflammation, give them gut rest, because anything you give them will worsen the inflammation, when there's things like, you know, butyrate, you know, short chain fatty acids, which have anti-inflammatory properties. I think the less gut rest we give them will actually probably be better. So a very long-winded answer, but in summary, completely patient dependent and depending on their symptoms.
Yeah, very subjective, isn't it?
Yeah.
Yes. So one more question here, if you don't mind. What would you suggest in patients who goes from days of constipation, so the other side of things, to days of diarrhea, always extreme side, both ends of the spectrum?
I guess refer them to gastro. I don't know, it totally varies, you know. It's when you have patients that have extreme constipation and then go to significant diarrhea, the thought, you know, you've always got to think, well, actually, is that overflow diarrhea? Do they actually still need disimpacting? Is the constipation not under control? So I think that's quite a difficult question to answer.
Yeah.
I don't see constipation in BMT.
I would say, but to be fair, I've had that, and I think it really depends on the context, because we've had children like that, but when you unpick it, they might have originally had a bit of overflow diarrhea. They've then been put on laxatives, then they clear, and then they clear the constipation, and then they have loose stools, really because they actually need to come with laxatives. And and then there might be that they get a chemotherapy that drives constipation or loose stools, or they pick up a bug, or they're on antibiotics. So I think I've definitely heard stories where the picture is so muddied, it's hard to unpick why, and it's seemingly without any cause. And I can't speak for this particular patient, I wouldn't have the information, but I would always encourage looking at when their treatment started, if they've got, stool virology that might be driving high stools. Have they been on laxatives a bit too long because they were constipated for a while? Maybe you've thought of all these things already, but I think often once you unpick all of that, it's not often just the feed, or very rarely, shall I say. But yeah, that would kind of be my approach. And I think it's very context-based and very treatment specific for the patient.
Yeah, actually taking the picture, the whole picture of the patient, isn't it? And the family, and also discussing with the team, because sometimes there may be an opinion or a medical opinion or other opinions
Yeah,
that
but
can lend a hand. Yeah,
what I would say, sorry to interrupt, Mary, is
yeah,
actually
that's fine.
if anything in those cases, moving towards food-based, like, encouraging any oral intake or fiber, I actually find when the gut seems to be in complete disarray, generally moving towards more of those things has been more beneficial than not. But again, that's quite general. I can't speak to the specifics of this patient.
Yeah, but good discussion. So now another question. Do you have a preference for the type of fiber feed? Example, always use feed containing real food ingredients or other alternatives?
Well, as our first line, I mean, we're an Abbott hospital, so our first line would be Pedisure Fiber or Pedisure Plus Fiber, as our first line choices, and that seems to be generally well tolerated. There've been occasions where we've had to move away from it, and we have used something like Complete Pediatric, so one that's a food-based formula instead. And it's not that it's even necessarily helped. It's normally in those patients where they've just got so much going on, GBHD, you know, multiple stool viruses that they've had chronically, in addition to, all the antibiotics and treatment and things they're on. So yeah, I would say that Complete would be the next step for me, but I generally don't have to do that very often.
Yeah, and I would say when our kids have gone into the community, if they're in a nutrition area and they've needed to switch to a nutrition equivalent, I haven't had any problems. So I don't think we use one because we're contracted to them, but I wouldn't necessarily say one is better than the other.
They would all move to their first line.
And in terms of Complete, I think obviously there's also the calorie balance, because obviously Pediasure fiber is 1 cal, Pediasure plus fiber is 1.5, and complete's 1.2. So it's also about balancing the fluid needs, the calorie needs, what the child tolerates. And I find in choosing between them, that's actually more of a driver rather than there's a preference between the food constituents and the fiber.
Yeah, and the taste as well, no? They come in
Uh,
different flavors or not?
Oh yeah.
Well, we're talking enterally, but
Enterally,
if you
yeah,
are talking orally, so the
orally.
Pediasure ones, obviously you can take orally. Complete pediatric is an enteral ped, so I doubt it would taste very good.
No.
So that would be another aspect. Quite right, Mary. If they're taking it enterally or orally, would also direct which we
Yeah,
choose.
and we have a mixed audience here across Europe, so the
Mm.
suppliers might be different. So for any attendees who want more information, so email Chiara Michi from the SIOP Europe office, and we can forward it on with the information. Okay, so one more question here. Do you have some literature like recommendations about nutrition during treatment for parents? Are there any literature out there for parents?
I mean, our basic introduction is using the CCLG booklet, supporting your child, with nutrition during cancer treatment. So
Yeah.
that will always be our first point of call, and that's where we talk them through our nutrition support options available, the dietetic provision we have. We talk about food safety guidance, and it's also got useful links and myth busters, the classics around like, should I give my child sugar? Can I take multivitamins? So I think we start there. And then if they've got specific questions over time, then we might do specific literature searches or provide additional support as needed. Would that be? And then BMT and high dose chemo, so autologous stem cell, we have slightly stricter food safety guidance. So we have guidance that we give them that our trust we've developed in our service.
Yeah,
Yeah.
and for
So
BMT, we have a health professionals booklet which has information from physio, psychology, social work, but also dietetics that speaks about, as Julie said, food safety, but also enteral nutrition and types of tubes, parenteral nutrition. But that gets sent to the family after we have an appointment with them to talk about all of the things in the booklet. Just because it's, without context, it's probably a bit confusing.
yeah, so I think in some centers they don't have dietitians. We have here Christina Petrova. Um, so Christina, if you want to get more information, we are happy to share information. But
Yeah.
if we go through Chiara Michi from the SIOP Europe office, so keep this in mind that the sender of this meeting invite is Chiara Michi from SIOP Europe office. So you've got the email, and then if you note down the session, which is on the 17th of June of this Nutrition Nugget webinar series, we can reach out to you with information. Christina, is that okay? Yeah. So, good. And with regards to our literature reading list, we can also share that, isn't it, Julie and Chloe? Yeah.
No
So we'll
problem.
reach out through the main contact is Charamichi. If you need any more information, okay? Are there any more questions out there? There are no more questions. No. How do you advise about the cost of this milk feed for centers who do not have dietitians to advise? Do you know the suppliers and how do you advise them? Or if they don't have dietitians, what would you recommend the medical and nursing staff do in terms of managing the nutrition?
Good
That is a
question.
good question.
We are so privileged to have their dietitians,
I,
isn't it? Yeah.
honestly, I'd probably try and reach out to other networks and other centres. So I don't know if it would be country specific or it's in forums like this, using PsyOp and actually saying it's about information sharing really in these specialist groups. And I think with the information that you garner, it might be that you're able to get put together a guideline. What we have at our centre with our provision may not be suitable in your context. So I think kind of reaching out, getting an idea of what is out there, whether it's through us, whether it's through other centres in your country. And then once you've got all that information, get together maybe a bit of a working group between the nurses, doctors, or what have you, and actually try and put together a guideline that you feel is appropriate. I don't know what it's like in terms of putting business cases together for dietitians. Obviously, we're an advocate, but there probably is something to be said about doing service evaluations and audits to highlight nutrition risk and to try and highlight that gap and then need for the specialist nutrition support that dietitians do provide. Yeah, I hope
That's
does
good.
that answer your question?
Yeah, yeah, that's good. Yeah, we share networking.
Yeah,
So,
always.
yeah. So if there are any dietitians in this group, you're welcome to join the SciOp Europe Nutrition subgroup, where we discuss all these matters to improve patient care. So we're going to round up the webinar now. We're going to finish soon. So I'm going to share my screen for your evaluation survey. Thank you, Julie. Thank you, Chloe,
Thank
for
you.
your interesting talk. And I'll share this link now for people to complete the feedback, because it will inform us about our next venture, our next webinar, which is on the 30th of June, the third webinar where we welcome Princess Maxima team to present and share their practice. So thank you very much. This is
Thank
the
you. Bye.
Bye, bye.
thanks. This is the survey link to provide your feedback, and I'll share with you the next screen for the registration to webinar 3. Is on the chat, the link to register for webinar 3. Thank you very much for your attendance today, and we'll see you on the 30th of June. Thank you.